Hi, I'm Ruth Asprey, a women's health champion, resilience and wellbeing coach. I specialise in perimenopause and menopause, and I also run a corporate wellness business. In my spare time, I like to take part in endurance sports like swimming, cycling, running. So avoiding leaks is my top priority.
Absolutely. Hi, I'm Faye. I'm a specialist pelvic health physio for the NHS with a strong passion for helping people of all ages, backgrounds, and genders to feel brilliant in their bodies. I'm also co-founder of the Pelvic Physios, and like many of you, I'm not just supporting others, I'm also navigating my own pelvic health journey.
And I'm Lizzie, a clinical specialist physio in pelvic health. I run an NHS clinic and I run the pelvic physios with Faye. Really lucky, love my job, love what I do and all the patients that I work with. And I've got my own first-hand experience too, for I am the proud owner of my very own vaginal prolapse.
Yay!
Great. And welcome to Oops, I Peed My Pants, the podcast that's here to break the silence, smash the stigma and get real about female incontinence and pelvic floor health.
Each week we'll dive into a real listener story. We'll share our thoughts, break down what's going on, and talk about practical ways to make life better. Expect expert advice, honest chats, and plenty of laughs along the way.
Yeah, and then after that, we're going to take a look at what we call What's Leaking this week. So this is where we dive into the latest news, hot topics, and anything that's making waves in the world of pelvic health. But first of all, let's find out how we all are this week, because we do pass like ships in the night, don't we? So what have you all been up to?
We do. Well, shall I show you my new fitness thing? Guess what this is?
Oh, is that a skipping rope?
No. I'd be lucky. A whip. It's a skipping rope.
Oh wow. How's it going? Have you tried it yet?
I have tried it, and I'm going to be doing some skipping to improve my running, because it's all about skipping, apparently. It's one of the things that you do. And I think I got to 10 skips before I felt like I needed a wee.
Oh.
My aim is to see if I can get to, I don't know, maybe 3-5 minutes of skipping by the end of the month. That's quite a lot.
Hardcore.
Yeah, skipping's pretty hardcore. It's quite impactful, isn't it?
Or 1 minute on, 1 minute off, something like that. But I will report back on the skipping.
Yeah, let us know how that goes and how it impacts your bladder as well.
Yeah, wear black leggings.
Yeah.
Yeah.
Or just no bottoms at all. Like
could do in the house. Yeah. So what's been going on with you girls? What's been happening in your world, Faye?
I've been hitting the gym quite a lot, and this week my Instagram must have known, because I don't know, guys, where do you sit on the fence with pants? Because I am a big pants girl. I haven't worn a G-string since I was about 16, and advertised at me on Instagram this week was a wide gusset G-string. I'm just thinking, do they know that I have large labia in there? It's a massive gusset.
What did it kind of go? This isn't something I prepared before, but I've got a lens wipe. So does it go like that, and then it goes like a string at the bottom like that? Is it like that? Is it like that?
It's like blue.
Sorry, that wasn't prepared. I was cleaning my glasses, so.
I didn't know,
I didn't know you could get them.
Well, no,
but this makes sense. We're all different shapes and sizes.
Yeah, I feel like I've got labia competition. I feel like mine are puny and you've got massive ones. I need to worry about this. I need to go to the labia library and check out.
Apparently, Khloe Kardashian's always going on about the size of hers. She's always complaining about the size of hers.
Too big or too small?
Too big. Especially when she's wearing it, because she's got that brand, doesn't she? She wears a lot of leggings and she's always complaining. Not that I always watch the Kardashians, but that's one of her things.
She needs these new larger labia thongs then, doesn't she?
Yeah.
See, Ruth, if you had larger labia, then that's got to be advantageous, because you're a cyclist, and that is very handy if you're cycling.
Why?
Well, because if you think like menopausally, we're going to a bit of this, but sometimes you get some labial shrinkage, and that's particularly chafing could be one way. It's quite problematic. I laugh, but it's actually genuinely a thing. If you cycle, it can be quite challenging postmenopausally because you haven't got as much coverage.
That's really interesting, Lizzie, because and maybe we'll cover this in the next future episode, because more when we get into more sports specific content, because you see a lot of women on the cycling forums are always complaining about saddle discomfort, and then they get sold these really expensive saddles for about 200 quid.
Right, ladies.
But what's been happening in your world, Lizzie?
I've been a bit like Jim. I've been like Jim at all. I've been like Faye and been to the gym. I go to the gym with my teenage daughter, who is she's like, sorry Faye, she's a great Faye and I used to be gym partners until I bailed and went to a different gym. It was to motivate my child to go to the gym, and she now kicks my ass out of bed every morning, and we go to the gym together, and it's a lot of fun actually. She's properly into it, and it's a really nice time to spend. Yes, I'm really enjoying that, and I'm actually trying to eat a lot better as well.
Yeah, me too. Right, are we ready then? Do we get into story?
Let's get into this week's listener story. Ruth, yet again, you haven't seen it, have you? So we're going to get your real-time reaction.
So we're doing story episode 3. So here we go. I'll get my best storytelling voice on. So I'll tell you a funny story afterwards about storytelling voice. But first, dear Lizzie, Faye and Ruth, looking back, my menopause started pretty quietly. At 46, my periods became irregular, and by 48, they had stopped completely. But at the time, I didn't really notice any major symptoms, just the usual changes. At about this time, I started a new relationship with a man. Sex was amazing, lucky thing. But then, out of nowhere, the UTI started. And I don't mean the occasional infection. I mean one after another, relentless. They got so bad that I ended up in hospital twice, hooked up to a drip. My life became a cycle of pain, antibiotics, and fear. And I was prescribed a low dose of antibiotics to take after sex, plus emergency tablets for when things got really bad. Like the time I was traveling and the pain hit me 20 minutes before the plane landed. Oh, the poor thing. Doctors brushed it off as honeymoon cystitis, even though I'd been with my partner for 6 years. That's some honeymoon. But the worst part, no one, not one single healthcare professional, considered that this could be linked to the menopause. I mean, that's a story we've heard so many times, haven't we? Then things got worse, hot flushes, aching joints, exhaustion. I felt a completely different person. Finally, I was prescribed HRG, including vaginal estrogen, and within months, I felt like me again. My body worked properly, my energy came back, and even my relationship started to heal. I did have to tweak my HRT because of some of the side effects, but I stuck to my guns and found one that suited me. Well done. Now that I finally have the right treatment, I feel like me again. My relationship is back on track, my confidence has returned, and life feels exciting once more. I'm so grateful to the menopause specialist who actually listened and knew what I needed. Well, that's a really great story.
Yeah,
isn't it? But it's one that we hear time and time and time again.
Sadly.
UTIs, they're horrible, aren't they? Well,
they are.
I've never had one, so thankfully.
So Ruth, we have with our stories been doing the piometer, but I don't know how that sits with this story.
I don't know. I mean,
think?
I think it's not. I mean, this week, and I know it's such an important topic. I wouldn't say it's a humorous. It's a horror story for her, isn't it? And I think it's a really high up there.
Yeah, agree.
I would go because it's so, I think it's a 9 or 10. This is, during this period, during your menopause years, so many things are happening, and it's a real, and I think it really impacts on women's mental health. So it's not so humorous this week. It's a serious number 9. It's a serious 9, isn't it? 8 or 9. What do you think?
Lizzie, what do you think?
I think I would go 9 purely because, well, actually, they can be really nasty, can't they? And to end up, it's got to be pretty bad to end up hooked up to, if you need IV antibiotics in hospital. So it's easily a 9 for me. 9 on the horror scale, it is. And they are so horrible, aren't they, UTIs? They make you feel so poorly, and they're so painful as well.
And the fact that she had to have those emergency ones. I didn't even know you could get the emergency ones.
Yeah, you can do. It's often if you've been sort of investigating a little bit, and they can't really sort of find a reason for it, or you get these long-term sort of infections.
Yeah.
So yeah, so some ladies, because some ladies genuinely, this isn't always what your long-term infections are, but yeah, and you can have either emergency ones if you keep getting them so they don't blow up, or some ladies will be on like a low dose long-term
So
antibiotic.
with the vaginal estrogen in this week's story, this has to be about vaginal dryness in the peri and post-menopause years, this vaginal atrophy, isn't it? It's not uncommon with quite a high percentage of ladies suffering with this without even realising that they're suffering. I mean, perimenopause years, hands up, did not have a clue. Hadn't heard of it before I did my training. So there must be a high percentage of women that suffer from this, Faye.
Yeah, absolutely. You're spot on, Ruth. This relates to vaginal atrophy. And did you know that vaginal atrophy has actually got a brand new name? Actually, it's not so new, but it's actually now called genitourinary genitourinary syndrome of menopause. Quite the mouthful, even for the pelvic health physio that says it all the time.
Yeah.
Don't ask me to say that tonight because I'm not going to say that.
Sure.
GSM.
Yeah, for short, we'll call it GSM of menopause. And the
Okay.
reason it's been renamed from vaginal atrophy is not just to challenge us with saying it, it's because it doesn't just involve the vagina. Like this poor lady mentioned, it involved her bladder, didn't it? So it can involve the bladder, it
Yeah.
can involve the vagina, the vulva, the clitoris, the labia. And the main reason that it happens is due to a change in the levels of estrogen,
Mm-hmm.
also in response to testosterone, but mainly estrogen. And we think that about 50 to 70% of women will experience some
Mm-hmm.
level of GSM in their peri to postmenopausal journey. Some people have it really mildly, some people won't even notice, and some poor people have it really severely, like our listener. And it can be really detrimental, not just to intimacy, but everyday life. Isn't that right, Lizzie? We just hear so many stories from our patients.
Oh, it's awful, isn't it? Like, it genuinely, it's no fun, is it, trying to chair a meeting when your vagina or your vulva feels like it's going to go up in flames, or you can't
Oh,
get through a lesson or a postal round, doesn't matter what your job is, without 50 trips to the loo or something. So, and I think the one thing to mention about this is it's not something that goes away. So if you're unfortunate enough to suffer from it, it's progressive. So unlike other symptoms of menopause, so like sort of after a while when you've sort of passed through that perimenopausal phase, and like the early start of menopause, things like hot sweats and joint aches can often settle down as your hormones kind of settle, but this doesn't. It tends to be progressive. So if it's left untreated, it can be really quite problematic.
so even when, so the symptoms that settle over time, once we get into that low, post-menopause and typically low estrogen stage, they tend to go to, what we're saying is this doesn't go away. Is that
No,
right?
it doesn't go away. It tends to settle. It tends to be progressive, and tends to go as. And it doesn't all, like some people have it quite early on, don't they, Faye, in the perimenopausal stages. But other ladies, I think generally, if you look at the literature, it tends to be most predominant around about 6 or 7 years post-menopause. Not always,
Post-menopause years.
tends to be, but you're not a textbook. Some ladies will really suffer with it perimenopausally. So yeah, but it's definitely progressive and it definitely needs managing, otherwise it can become quite problematic.
So it gets, so we're saying, so it goes, so 5 to 7 years post menopause, but then it varies, and so the symptoms are quite wide ranging. So how would a woman know? What are the symptoms?
So we've got so we've prepared especially for you. Oh, I had a little stutter then, especially for you, a sort of GSM charts for ladies, but instead of we agonised over this via this other person that might not want to be mentioned on the podcast, so I'll leave him unnamed, but we agonised over the name of this. So we've got a GSM sort of top of the pops, but I feel like with all the other things that go along with the hormonal changes, it's more like a slap in the flaps.
You
And then the thing like, you can't call it that. I was like, well, I just did anyway.
Where did you get that name?
I don't know, just my inner genius popping out. And then I was just having a little daydream over a pint of everything. And then I thought, could be groans in the groin, size between the thighs, like rants in the pants. And then this person came, oh, genitals, I quite like that one, or hits of the bits.
Hits of the bits.
Well, then we were chatting late at night, and then I said, oh, what about naming it after like an English classic, like you could, like a little play on words like the Canterbury Tales. And I was like, no, that's just too
No,
far.
no, you can't. You can't. You can't.
Like, well, it's created
No,
quite
that is.
a
No, I
conversation.
have to say that is the first time we've mentioned it on the podcast.
Oh yeah,
See you next Tuesday.
See you next year. Yeah, Sarah Rosen had a good. I was listening to a good thing about that the other day. But anyway, that's another thought. But yeah, so I think in the end, I quite like to slap in the flaps. But so I joke about this, but it is quite serious.
Yeah.
And from my, and probably Faye will say the same, some of our sort of clinical experience, it can be some of the most disturbing and the worst symptoms of menopause. And it can kind of sneak up on you quite a little bit. So listening as getting help with this, I think, is a really life-changing thing.
Yeah.
So I'm going to hand over for slap of the flaps to Ruth.
Well, I'm going to be a bit more. I'm going to read the list of the GSM top of the pops. I'm going to be a little bit more sophisticated than you, Lizzie.
Right.
And you can help me out with a few of these because I haven't. You can help me out. So number one, and just stepping back to the pants thing. Okay, this is probably why all of a sudden we move from the little pants to the big pants, isn't it? Without you even really knowing it. In your 40s, you're kind of in your 30s, you're still rocking the G-string. Well, I was, and then all of a sudden the big pants are in. So this is the reason why, ladies, why the big pants are made an appearance in the drawer. So at number one, we've got vaginal dryness is the most common, with 98% of people experience it. Then we get itching, dryness and discomfort with sex. And at number 4, we've got, is that hypersensitivity? Because it may find it more difficult to orgasm. So even if you're still in love, you might just, the vagina's no longer in love.
So it can be hyper, so you can be more sensitive, or it can be hypo, and you can have less sensitivity.
So it's not just the vagina, that's like clitoral sensitivity as well.
And so number 5, leukorrhea, is that how you say that?
Leukorrhea, so changes in your vaginal sort of discharge. So some people find they get much thicker discharge, but quite commonly I see either no discharge at all, or it becomes quite thin and watery. So it doesn't sort of hang, so it doesn't sort of do its job properly, really. It doesn't sort of hang around and keep the membranes kind of moist. It can feel it can almost feel like you're damping, like you're leaking a little bit as well. I find when you say, well, and I sniff it, but it's not a wee smell. What is that? And often that's what it is.
Right. And then urinary symptoms, so needing to pee, urgency, frequency. Needing to pee at night time. Urinary tract infections, so like that lady had in her story. And then we've got labial changes. Have I said that correct? Inner and outer, loss of fat and tissue and hair.
Labial changes. So you might need your big pants.
Right. And then smear test. So smear test examinations become painful when they're previously not. That's really interesting. Hey, this is really useful for the community. We'll put this as a list so that women have got this as a checklist within the community. And then if they've got any of these, when they go to the doctor or their pelvic floor specialist, they can actually take this with them, because there's a lot here that even as a menopause specialist, I didn't know the details of a lot of this. So it's really interesting stuff.
And not forgetting, I suppose, actually thinking about, you popped down here a note to say about, obviously some of these can be, it might be that you have got a repeat infection, or, we've sort of said they're having non-infective cystitis. So make sure if you get these symptoms that you are going to your GP. And with the leukorrhea, if there's any change in your vaginal discharge, and obviously the first thing that you're going to do, isn't it, is pop down and either see a practice nurse or your GP to make sure that it isn't, we'll talk about this later, something like bacterial vaginosis or some other kind of thing.
So
they still need checking out. It's just being aware that these are some of the common symptoms.
And then, you know, the symptoms are quite generic, but, you know, the one, you know, discomfort with sex or blood or anything like that, it's straight to the GP, isn't it, to get checked out? Yeah, absolutely.
Yeah.
So is there anything else that needs to be ruled out by a GP or a specialist? Or, you know, so for example, if one of our listeners has vaginal dryness or one or two of these which are mild, would you recommend that she goes just to get checked out anyway if she's suffering from any of these?
Yeah, oh, absolutely. Because like I say, they are quite sort of generic.
Yeah.
And, you know, things like persistent itching, they can be indicative of something else. So although these are super common, it's really handy to go to your GP.
Yeah.
They're brilliant. Like the ones that we deal with around here are amazing. And just check. So, you know, itching, bleeding, soreness, discharge, it can be caused by lots of things. So little things like there's some skin conditions that you can get, like lichen sclerosis, lichen planus, and a couple of other little sort of issues like some of the gynae cancers. So don't all panic if you've got these symptoms. It's just a case of, actually, the sensible thing to do is, these could be symptoms of absolutely anything. Pop to your GP, or if you happen to be going to see a pelvic health physio and you haven't been to the GP about it, you know, talk to them about it. Generally, I think we're quite knowledgeable as a population within that specific area, aren't we? And often we can provide reassurance and sort of say, well, this is what I think it is, but still bob back to your GP just to get it checked.
Just on that GP, because I'm post-menopause, and I've been through a couple, and I'm also on HRT, so I've been referred to the gynae twice now since I've been on HRT. Everything was fine.
Yeah.
But I have to say, no, this is why I think this list is really useful to have out in the community, because at no point did the GP ask me any of these questions. Like there was never. It was just, oh, well, you've had a bleed. So I don't know. It'd be interesting. I think this is an interesting conversation that we can have within the community when we get the community up and running. I think this is really important because I was certainly not asked any questions like this. And I don't know whether
it's really difficult, isn't it? Because GPs down here are brilliant, but it just does depend. And I'm terrible. I'm always sticking up for GPs. I think because lots of my friends are GPs, they can't be specialists in everything. So just like you'll have somebody that's like massively into gynae issues. I think if you've got a gynae issue, if I've got some common issue. So when I wanted HRT, you know, I rang up my GP and went, don't care how long I wait, can you, or who's in today that's actually got an interest in gynae? That's how I, or, you know, whatever I've got, is there anybody with an interest in cardiac issues? Or they can't be brilliant at everything. And also not forgetting that until fairly recently, all this kind of stuff wasn't bog standard in their training either. So I think sometimes it depends if they've done an obs and gynae rotation as an SHO, or I think it up to date, it has just depended on what their clinical experience is. Like there's certain subjects that I'd probably be terrible at as a physio because I didn't do it. Orthopedics would be one of those. But you know, and I haven't sort of pursued that, and I haven't got particular interest in that area. But and it'd be the same with sort of GPs as well. So they can't know everything about everything. So I think if you keep yourself quite well informed, then just finding a GP that you find easy to talk to, and most of them are great. I think if they don't know something, they'll just go away and find out about it, won't they?
Yeah. And we commonly, you know, patients will come into our clinic and they'll tell us about these symptoms, and then we may write to their GP and say, you know, your GP is going to see you and maybe it's vaginal atrophy, or maybe we think they need to investigate something else. While they're waiting to see their GP, there are other things that you can do to to help your symptoms. Genital hygiene is always the first thing I ask my patients when they complain of any itching down there. And it never ceases to surprise me the amount of scrubbing or soaping that can go on. But then again, if I think back 20 years ago, I remember the advertising of things like certain shower gels that were pH neutral and certain feminine washes. And yeah, lots of people using those on their genitals. You don't need to use any soap. So what we want is just water being used. We don't want anything that's going to be stripping away any of the natural oils in that area, because that will lead to irritation, and perhaps bits of soap remaining on the skin will cause irritation as well. So just strip back to warm water. If you feel like you need something, when you get to your GP, they can give you an emollient cream to wash with. Did you have a question, Ruth?
I did. Are you recommending that for all? Is that for women who have itchiness or have an issue not to use soap, or would you recommend no soap for women?
No, all women. No
All
fuzzy
women.
down
Yeah,
there.
the vagina is self-cleaning, and so you shouldn't be cleaning inside of the vagina because the vagina is the internal bit. In terms of like your labia on the outside, the
Yeah,
vulva, you should just be using water, just tepid water. Definitely no scrubbing. If you feel like you need something because you've gotten
yeah,
used to using something, an emollient cream, you can get that over from the pharmacy, or you can ask your GP to prescribe it. So
right,
that's the
okay.
first thing I get
I
people to
use
do.
that's really useful. I use that pH neutral stuff, so not much, but I use it but what we're saying is no, so that's really interesting. Thank you, Faye.
Yeah, so ideally take that out. And then for some of us, we might want to get started on things straight away. Some of my patients are quite keen to be adding the moisture back in. And so what they can
Yeah,
do there is buy something like a vaginal moisturizer. There's some brilliant brands out there, particularly ones that have something called hyaluronic acid in. Now, I mean, I love hyaluronic acid. I'm mostly applying it on my face. It's one of the trendy face serum things, isn't it? But vaginal moisturizers, yeah, they can have those in. There's different types. There's water-based, there's oil-based, and there's loads of brilliant brands out there. Lizzie and I like a brand called Yes, particularly because they've had a lot of studies done that have shown that most people don't react to those. And then looking more widely at your health, are there things that you're doing that are contributing to the quality of your skin in general not being brilliant? So things like smoking are shown to have an effect on your skin. It particularly speeds up the metabolism of estrogen, and then that will have a negative impact on blood flow and tissue integrity in the whole body. But yes, that will impact your vagina. And then generally, vitamin D is brilliant for everything, isn't it? So check your vitamin D. Are you taking it? What the NHS says is that everybody within the UK should be taking vitamin D. It's really important for our immune function, and it's known to have a positive effect on sexual function as well.
Yeah. Also, and the partners are going to love this, regular sexual activity. Love that one. My husband was jumping for joy. Been trying to convince me about that for years. So regular sexual activity. So it's not the answer, obviously, if it's uncomfortable or if you don't want to be sexually active. That's the thing. So what we're definitely not saying is, in order to prevent your vaginal atrophy or your GSM, you need to crack on and have loads of sex. That's definitely not what we're saying. But ideally you would deal with that sort of discomfort first, wouldn't you, with your vaginal estrogens and whatever. But you can use, there's a, sort of, they do recommend sort of like use of vibrators, which can be useful for sort of regular stimulation. So it doesn't have to always be penetrative sex. It just increases the blood flow around the area. So that could be on your own, have fun on your own. Sometimes it's more fun on your own, or it could be with a partner, whatever, and certainly if that's not the kind of thing that you're comfortable with doing, again, not sort of we're not sort of saying this is a must do. It's just a useful thing to know. So use of vibrators, and if you're happy doing that, regular sexual activity can help with the blood flow around there. And then also thinking a little bit more widely.
It's more of a maintenance, isn't it, Lizzie, rather than the solution?
Oh, yeah, you wouldn't kind of go, right, so use your vibrator every night of the week to get rid of those. So it's more of a maintenance thing. Hip mobility and strength. Okay, super important in terms of improving leakage and sexual function. So you could apply that to any age, actually. We see quite a lot of people with pelvic floor issues that we look at hip stability and hip strength. And just generally being physically active, you're less likely, or rather you're more likely to have these issues as you do many other issues if you're less physically active. So definitely physical activity, and then not forgetting the good old pelvic floor muscles. So a good sort of, if we're looking at permanent changes with pelvic floor strength or function, you're looking at a minimum of 12 weeks regular training, just like you are for any other muscle group of the body. But it does improve the blood flow, it improves your muscle function, it improves your confidence, definitely improves sexual function. So it can improve sensitivity. with sex as well. It can give you a better orgasm because obviously your pelvic floor is super active with orgasm. And I put pelvic floor relaxation down there. Just making sure that your pelvic floor, that you are able to fully squeeze and fully relax your pelvic floor, because obviously if you're quite uncomfortable down there and you've got super tight pelvic floor, because anything that's uncomfortable, we tend to grip a little bit, that in itself will cause a bit of pain. And obviously best way to do that is go and see a good pelvic floor physio, whether that's private, NHS, get a vaginal examination.
I'm loving these answers. I'm loving the sex, the vibrators, the hip mobility, and the physical activity. It's basically
the Kama Sutra, aren't we?
It's basically Kama Sutra. Oh, let's do a whole episode on that. It's basically, well, it is. Look, that is well-being, isn't it? It is well-being, isn't it? It is taking responsibility for our whole body, isn't it? And it's saying there's not just one fix. Doing a few squeezes in a Pilates class isn't going to fix it, is it? Or do it. You've got to do it. Yeah. So I love these answers. There's one thing that I wanted to discuss also is, what about vaginal estrogen? Isn't it supposed to be the wonder for it?
Yes, it definitely can be. Ideally, it be combined with the treatments above. If you're someone who's scrubbing at your vagina, if you put vaginal estrogen in there, you might still have a problem. So we want to be looking I think why Lizzie, and part of the reason Lizzie and I love our job is because we are so holistic, aren't we, Lizzie? Like we don't just look at one aspect of someone's treatment, and then we look at all different things to optimize their health. So vaginal estrogen, it can be a wonderful thing. So first of all, how does it work? So in our bladder, vagina, urethra, even our pelvic floor muscles, we've got lots of estrogen receptors. And during the perimenopause, menopause, obviously that estrogen is dropping and those receptors are not being stimulated. And when they are stimulated, what happens is they actually relax the bladder. So when you go for a wee, or when you know you need a wee, the reason you know you need a wee is because your bladder is starting to squeeze and it's sending little squeezes and messages out through the nervous system to tell you, oh, I need a wee. What estrogen does is it basically calms that down. And so when the estrogen goes, your bladder might not be full, but your bladder is still squeezing and telling you need a wee, and therefore you feel urgent for the toilet. Vaginal estrogen can also increase blood flow, and if it increases blood flow around the urethra, so the urethra is the tube which the wee goes from the bladder to the outside, you've got lots of blood supply around that, and when there's lots of blood going through those vessels, there's lots of support, and that basically keeps the urethra closed. When there's not a lot of blood supply, it's like it slackens and the urethra can open and you can be more likely to leak. And we also think that the estrogen can support collagen production, and that's anti-aging basically, isn't it? You can
put a bit on your forehead.
Yes.
So could I get rid of that if I just apply a bit of vaginal estrogen there? Don't try this session, thanks. It's not in the clinical guidance, but I have one.
That's one of your jokes, isn't it, Lizzie?
Yes, it's a joke.
It's
Just
a
establish
joke.
that now, listeners. Lizzie has, as you will get used to over the coming episodes, Lizzie has a very funny sense of humour. So don't be putting anything that needs to go in your vagina on the top of your nose.
No, I'd never do that. Yeah. Or on your clothes.
Right.
Yes, vaginal estrogen. Yes, it does come in a cream, like Lizzie's just mentioned there. It can come in a ring, it can come in a gel, and it can even come in a pessary tablet. Some of my patients could get quite panicked when I mention vaginal estrogen. And what I have to remember, and we want our listeners to remember, that we're pelvic health physios. We are not prescribers, so we're not qualified to write a script and give you medical advice specific to drugs. your individual health and ability to have drugs needs to be assessed by your GP. So first of all, if you're interested in vaginal estrogen, you need to go and speak to your prescriber or your GP. But what we do, we're educated on it, and what we do know, all of us, is that medications have risks and side effects. And so if you go and speak to your GP, and they'll be able to help you work out the benefits and the risks for your particular individual circumstances. I went away and had a look at the NICE guidelines. So for those of you who don't know what NICE guidelines are, they're essentially healthcare guidelines that healthcare professionals within the NHS follow, and they're based on the latest research. So they're really reliable, robust, evidence-based guidelines. And what that says about vaginal estrogen is that there are rarely negative side effects. So it is a pretty safe form of medication to use. They say that the vaginal estrogen, the estrogen in that, is only absorbed in the local area, so just in the vagina, and it has no effect on breast cancer risk for people who have not had breast cancer. And that's the main question I get from my patients. Oh my gosh, it will increase my risk of breast cancer. And if you've never had breast cancer, no, it will not increase your risk of breast cancer. If you have, you may be able to take it, but you would absolutely need to go and speak to your medical professional, because everybody's cancer is differently. Anecdotally, most people in my clinic, most people seem to get on with it. The occasional problems that I may see is maybe a bit of irritation, like that don't get on with the cream, maybe a bit of breast tenderness and occasional moods. But with all those things, you just stop using it if you don't want to. But it has so many benefits, and that's why we talk about it in clinic. It can reduce urgency, reduce leaks, it can make your skin so much more comfortable. And if it's increasing the collagen, it's basically having anti-aging effects on vaginas. And in clinic, when I see patients, even in their 60s, late 60s, who've never used vaginal estrogen, and then I examine their vagina 6 months later, honestly, it's like their vagina's gone back in age 20 years. It can be an incredible medication. What they do is, if my patients get on with it, they first of all start off with using it. Generally, on their packet, it will say to them, you need to use this every night for 2 weeks. And after that, you use it as a maintenance dose. So if it works for you, you're going to continue using it twice a week. And yeah, it can work so well, can't it, Lizzie?
Yeah, it can do. Yeah, and it's just remembering as well then that if you don't want to take it, and there's all that lovely advice, or you can't for any reason, there's all that lovely advice above. But so yeah, it can be a little bit tricky, can't it, to get vaginal estrogen. So as Faye's alluded to, if it's usually if there's breast or gynae cancers involved, the big thing is it's not usually a flat no. But as Faye was just saying, you need to go and speak to your oncologist. There are a few little cancers that it's not great with. Or quite rightly, some people are like, but I've had an estrogen-driven cancer. Why would I want to put any estrogen anywhere near me? And that's absolutely fine. And that's where your other factors, your judicial use of the vagina moisturizers, in particular the hyaluronic acid ones, and and all those other factors will really, really help. I think we're still really looking for some really good non-hormonal alternatives for ladies. So that's it. Have that conversation with the GP. Often, if there is gynae cancer involved, they're going to want to involve the oncologist as well. So it's completely fine. Don't get frustrated with the GP if they won't prescribe it to you, because at the end of the day, they're responsible for what they prescribe, and they've got to prescribe what they feel is right and safe and within their sort of scope of practice. So that's something I'm often sort of saying quite a lot of. So whether you want to take it or not, and whatever decision the GP or whoever makes, it's just to be respected, isn't it? Really, you can always go and get a second opinion or whatever. So
very personal decision, isn't it? So
and I've had people with no history of cancer, and they just don't want anything hormonal. They want to go down the natural route, and that's fine. But if there are concerns and the GP is not happy to make that call, which is totally acceptable, then often you will have a specialist menopause clinic and an oncologist, and they should speak to each other, or the meno specialist might be happy to do it on their own. So for ladies that prefer non-hormonal alternatives, they've given you lots of great tips, which perhaps we should put those up on the as a resource as well.
Yeah, but we like the lifestyle changes we mentioned earlier first, and then the vaginal news. Right. So
hang on a minute, I haven't finished.
Well, then there's more.
Yeah, there is only a little one. So a few years back, in fact, we snuck it in just for COVID, organised like a little menopause conference. And the most amazing lady wrote a book called Me and My Menopausal Vagina, Jane Lewis. It's a great little book. It's thin and it's really easy to read, so that's why I read it. She was brilliant and she came to talk about it. It's a great book. And it's such a lovely read to hear about, because she had breast cancer several times over, I think, and had the most horrendous time with vaginal atrophy. So it's a lovely, sort of clever lady. Honestly, I could have sent all the consultants home. She was so well read and brilliant. It's definitely worth a read. That.
Do you think we can get her on? Should we get her on? Because this is a big topic. I mean, we have been talking this is a lot to unpack in this episode, so it would be great. Let's try and get her on for
what a woman.
Series 2. Yeah. Just quick, I know, because there's so much to unpack in this, and you know, we'll put all the information in the show notes, and then hopefully we'll get Jane Lewis on in the next. Maybe she's listening, so it's a call out to you, Jane. If you're listening, we'd love to have you on. Okay, fantastic. So, I know it's a big topic, but what about any rejuvenation therapies? I know we might cover this in a later episode.
Yeah, so perhaps cover that. We'll perhaps do a little bit more on that. I have seen, I don't know about you, Faye, I'm seeing a few more people come through with this. So these are the two sort of therapies that are out there, are the Juliet and the Mona Lisa therapy. So the idea being that they improve the blood flow and elasticity of the vaginal tissue. So it's like a non-hormonal alternative, I suppose, really, isn't it, to vaginal estrogen? So the evidence is getting there with that, and there does seem to be some great results. But looking at the sort of the guidance that's out there at the moment, the RCOG, so that's the Royal College of Obs and Gynaes, feel that there needs to be a lot more robust evidence to confirm these benefits. So at the moment, it's not available on the NHS, is it? It's a privately funded thing.
Right. Okay.
So it's not prescribed as it were yet. Definitely needing a bit more evidence, but it's just important that people know that they're out there.
Right. Yes. Okay. So to summarise, ladies, because this is a big topic and one I'm sure we will revisit in later episodes, in up and coming episodes. So to summarise, GSM is progressive. It doesn't get better on its own. There are both hormonal and non-hormonal management options. Ideally, you would combine. The main thing to rule out any other causes of the symptoms, to be informed of all your options and choose what is the right one for you. This may involve a GP, menopause, or oncologist as appropriate. So if we've got any listener questions, they can email them in on this topic, or any other topics. But you can, any questions, then leave them in. So yeah, this is a big one, and there was certainly some great stuff there that we covered. So right, it's time for what is leaking this week. I feel like we need a new jingle, don't we? Oh no, Faye, you're the jingle.
What's leaking this week? What's leaking this week? Leak. What's leaking this week?
What is, and I'm gonna, you know what, you're not giving me this bacterial BV. How do you say bacterial vaginosis? Vaginosis. Or might actually be an STI, so a sexually transmitted infection.
So for years, we've always understood it to be sort of a hormonal imbalance more than anything. So quite common. It's not uncommon, is it, postmenopausally? But yeah, it turns out that sort of it might be, it's not, well, it's triggered by sex, but it hasn't been classified as a sexually transmitted disease. But now looking at the research, it's saying, surprise, that it does actually behave like a sexually transmitted disease. So we're starting to change our minds about what we think is the cause.
Indeed. So a study found that treating just one person in a couple wasn't enough. When they treated both partners, the reoccurrence of the bacterial vaginosis was halved. So the old just pop some antibiotic cream on and move on approach, not so
It's
effective.
not, and it's
Well, that's interesting, isn't it?
and it's incredibly common, isn't it? Affecting nearly a third of women worldwide, and it can cause discomfort, discharge. Is it that the fishy smell?
Yes, it
Fishy
is.
smell, isn't it? But half of people who have it don't even get symptoms. So has BV been gaslighting us this whole time?
Whole time. Yeah. So, and also what is really mad is that researchers, we still don't know exactly which bacteria are to blame. So yeah, it's a bit like a crime thriller. They found the fingerprints, but not the culprit. You can tell I'm a police wife, can't you? And then, but thanks to genomic sequencing, that we are getting a little bit closer to solving the mystery.
So what does this mean for the future then? Are some sexual health clinics are already changing their approach and treating both partners? That makes sense. If we do it for STVs, then why not BV?
Yeah, it does make sense.
Yeah. And will it like change official guidelines? Because at the moment, that's not what's offered. It's not being offered to the partners of people who have BV. It's just been offered to the people with BV. I guess more research is needed, isn't it? So that we can break this cycle of endless BV that I see with some of my patients in clinic.
It's a bit like thrush, actually. I was having a conversation today about thrush, as I do. But yeah, you've got to treat your partner as well, haven't you? And I think it's not always quite as obvious in men as it is in women. Otherwise, it's a bit like when you're breastfeeding. If you've got if you get thrush on the lovely nipple thrush, which you all get from breastfeeding, you just pass it backwards and forwards. It kind of makes sense, doesn't it? So
yeah.
So the moral of the story: if you're dealing with recurrent BV, it might be time to drag your partners to the clinic with you, kicking and screaming, because sharing is definitely not caring when it comes to bacteria.
So any listeners thinking that sounds like me, what's the first step?
Number one, go and speak to your GP. Choose one that has an interest in women's health. Before you go, if you can, make a note of your symptoms and your questions. There's nothing worse than leaving the clinic room, is there, and going, oh, I forgot to ask that question, or you forgot about that symptom. So go prepared. And also, I know it's hard, but try not to be embarrassed. I promise you, your GP will have heard all about this before.
Yeah, definitely. So we'll put some useful links in the show notes to some resources as well. And there's some brilliant websites out there full of like really good, reliable information. So rather than randomly Googling, have a look in the show notes and we'll try and head you off in the right direction.
Yeah, great stuff. And if you've experienced anything similar, then let us know and email us with any questions. So how do our ladies and our listeners get involved with the show?
We want to hear from you, lovely listeners. Please submit your stories and questions either via our Oops, I Peed My Pants podcast at gmail.com or our Facebook community, Oops, I Peed My Pants podcast. And is there a link on the website as well, Ruth?
There is a link on the website.
Yeah, so there's a link to a form to fill out with your story on oopsipedmypantspodcast.com.
Yeah, and the more outrageous the story, the better. Like I really want someone to send in like a really like, I don't know, like a really out there question. I can't wonder.
I know somebody who sent one in. I've got a good one coming in. I was talking to a client who sent a good one in. I know today's topic was a big topic, and may not have been as humorous as last week's, but that's why we want to hear your stories, because let's reframe the narrative around incontinence together. All the details in our show notes are below, so please subscribe, join our Facebook group, and let's break the silence, one laugh and leak at a time. Thanks, ladies. Great show.
Thanks. Yeah, it was ace. Love that. Bye.